Recording in progress.
Good evening, everyone. In today's session, we'll be discussing about TMJ imaging. So the contents include TMJ anatomy, TMJ imaging, which will be discussed under two headings, hard tissue imaging and soft tissue imaging. Under hard tissue imaging, we'll be talking about plain film radiography, which includes your transcranial, transpharyngeal, and transorbital projection. Then comes your reverse down projection, panoramic imaging, and tomography. In soft tissue imaging, we'll talk about MRI and arthrography, and then we'll conclude the session. So moving on. So first, we'll be talking about a temporomandibular joint anatomy. TMJ is a gangliomo-arthroidal joint, allowing a hinge-like movement combined with an arthroidal gliding movement. That means initially in the phase of opening till 20 mm, you have the joint being in a hinge movement. And once the opening is being made more wider, it is going to be in a gliding motion. Okay, so that is what is being meant by this term. The hinge-like movement represent the first half of the mouth opening, whereas the sliding movement represent the second half. Okay, and also it includes the protrusion and the lateral movements. So coming to this picture, this is your condyle. This will be your articular disc, inferior and superior synovial cavity, glenoid fossa, and articular eminence. Okay, so we'll moving on, we'll get a clearer picture. So this is a more clear version of what we were talking about. So this will be your condyle, okay, and this is your articular disc, okay. This is your glenoid fossa, and this is your articular eminence, okay. So that is how it moves. Then the articular disc is a biconcave structure composed of dense fibrous connective tissue, and it is divided into thicker anterior and posterior band and a thinner intermediate zone. So you can see over here, this is your articular disc. It is thin in the center and it is thick in anteriorly and posteriorly. Okay. So this is the anterior aspect. It is being getting inserted to. So this is the anterior aspect. You can see over here, the disc is getting inserted to the lateral pterygoid. Okay, lateral pterygoid, and also to the neck of the condyle. Okay, so you can see over here. 1 second. So this is to the lateral pterygoid and to the neck of the condyle. Coming to the posterior aspect of your articular disc, it is getting attached to the temporal bone, but the posterior aspect is innervated. Okay, so that is why once in case of disc derangements and all, the condyle coming and resting in the posterior aspect, the patient may feel pain. Okay, so that is why the posterior aspect is innervated. So that is a more clear picture of your TMJ, TM joint. This will be your condyle. This will be your articular disc. This will be a glenoid fossa, and also this will be your articular eminence. And one more thing, the joint space is being divided into the superior joint cavity over here. Okay, I'll show you over here, superior joint space and inferior joint space. Okay, so that is two more things that you will have to keep in mind. So TMJ is a synovial joint whose common features is represented by a disc. We have seen the articular disc, bones, that is your condyle and your temporal bone, the fibrous capsule that we have seen, intra-articular fluid, that is the fluid that is being present in the superior and inferior joint cavity, a synovial membrane, and the ligaments, that is your capsula and the collateral ligaments. The articular disc, that's this point we have already told, it is a biconcave structure that is composed of dense fibrous connective tissue. And posteriorly, the disc is attached to the temporal bone by the retrodiscal tissue. It is highly vascularized and innervated, that we have told. Anteriorly, the superior biliary lateral pterygoid muscles inserts into the disc. Okay. So this is a more clear picture of what we were telling. So this red part that you can see over here, coming here, in the first picture, this red part will give you a picture of your articular disc. Okay, this is a soft tissue component in your TMJ. This is your mandibular fossa. This is your articular disc. This is your articular eminence, and this is your condylar head. Okay, so this is how the joint looks. So this is your disc in a more clearer picture. Coming to the second picture, this is your disc, okay, anteriorly being attached to the lateral pterygoid and the neck of the condyle, and posteriorly it is innervated and it is attached to the temporal bone. Okay, so this is the superior joint space over here and the inferior joint space. Okay, so that you can keep in mind. Coming to the TMJ imaging, why do we have to do a TM joint imaging? So first thing is to gain additional insight regarding the health and functions of the TMJ. Once the patient is coming with some painful symptoms over the TM joint, so to get a clarity of the diagnosis, we can take a TMJ imaging. To get information regarding the morphological characteristics of the bony components of the TM joint. So if there's any change in the morphology of the bone, say in case of arthritis and all that, so that you get to know, and to certain functional relationship between the condyle and the fossa. So is the condyle and the fossa in a proper functional relationship, or if there's any derangements, or is there any impairment in the motion? Okay, motion of the condyle in the fossa. So that is what we get to know in a TM joint imaging. So once a patient is coming with some painful symptom over the TM joint region, for us to diagnose it in a proper way, we can take a temporomandibular joint imaging. So it can be discussed under two headings. It is your hard tissue imaging and your soft tissue imaging. Under hard tissue imaging, first we'll be discussing about plain film radiography, which is your transcranial, transpharyngeal, and your transorbital projection. Then we'll talk a little bit about the reverse turn projection, panoramic, and then tomography. In soft tissue imaging, that is mainly to visualize your disc. We'll see what is the MRI and arthrography to do with TMJ imaging. So first, we'll be talking about the hard tissue imaging, under which mainly we have the plain film radiography or the conventional plain film radiography. It is made with a stationary X-ray source and the film, same like your IOPA. We use a bigger film and a PID to see the various aspects of temporomandibular joint. So in order to avoid superimposition of the adjacent anatomic bony structures and to visualize all parts of the TM joints, different projections have been applied. So we have a question, like we have different types of plain film radiography, right? We have a transcranial, transpharyngeal, and transorbital. Why do we have to take different projections? So the answer is given over here, in order to avoid superimposition of the adjacent anatomical structures and also to visualize all parts of TMJ. Okay, so that is why we take from different positions. So first we'll be talking about transcranial view. So transcranial view is the most popular imaging technique of the TM joint. It provides a good visualization of both the condyles and the fossa. So a point to remember from this is that it get to see the lateral aspect of the joint. Okay, so we can very well visualize the lateral aspect of the joint with the help of transcranial view. Okay, so that is one point to remember. The central and the medial parts of the joints are not clearly being seen because the X-ray beam is not tangential to these articular surfaces. So just remember that it is the most popular imaging technique, and we can very well visualize the lateral aspects of the TM joint in this view. Then what are all the indications? So when are we going to take a transcranial projection? To study the position of the condyle in the glenoid fossa. Okay, so that is one thing. So we have a condyle and we have a fossa and this articular eminence. So to study the position of the condyle in the glenoid fossa, to study the joint space, that is a space between the articulating surface of the glenoid fossa and the condyle for either partial or complete obliteration. So if in case there's an ankylosis, okay, that means these two are clubbed, either a bony ankylosis or fibrous ankylosis. Okay, so if at all there's no joint space and all that, that can be visualized with this. Then to study the anterior posterior mobility, that is, if there's any hypomobility, if there's any disc derangements, or that can be visualized, and to study the osseous changes such as flattening in case of arthritis. Okay, in case of any arthritis or anything, is there any change in the morphology of the condylar head or in the articular eminence. Okay, so that can also be visualized. So basically, in order to find out the relationship of the condyle with the fossa, if there is any disc derangements, if there's any hypomobility, if there is any morphological alterations in the TM joint. So that is why we are going. That is how we are going to be take transcranial projection. Now coming to the technique. So whenever we are explaining about radiographic technique, we need to know three things. That is your film placement, positioning of the patient, and the central ray. Okay, so that is what we are going to discuss. How are we going to place the film? So you can see in this picture the film. So this is how the cassette will look like. Okay, or the film you can see over here. So it is placed flat against the patient's ear, center of the TMG of interest, parallel to the sagittal plane. This will be a sagittal plane, and this is how this cassette will be placed. Okay, the film will be placed. And how are we going to position the patient? The patient's head is adjusted so that the sagittal plane is vertical. The alar tragus line is parallel to the floor. Your alar tragus line will be parallel to the floor. And the view is taken in three position: open mouth position, rest position, and closed mouth position. Okay, so you are going to make the patient sit straight with the sagittal plane vertical and the alar tragus line parallel to the floor. And you're going to ask the patient to open the mouth in rest position and in closed mouth position to take this particular radiograph. Now we will see how are we going to project the central ray. The point of entry is different according to the technique used. So we have three different techniques that we will see in transcranial projection. In all the three techniques, the central ray is directed caudally at an angle of plus 20 to 25 degree. Okay, so this particular point you can remember, we are going to use an angulation of plus 20 degree to plus 25 degree. Okay, so that is the angulation that we are going to use. So according to the point of entry, it can be divided as three techniques. Okay, we'll see what is it. First is post auricular or Lindborn technique. Okay, so what is happening in this? The point of entry of the central ray is half-inch behind and 2-inch above the external auditory meatus. According to Lindborn, the central ray should be directed from posteriorly so that it passes along the long axis of the condyle. Okay, so this point you can remember. So the central ray is half-inch behind and 2-inch above the external auditory meatus. Now coming to the second technique, it is your Grewcock approach. Okay, so the second one is Grewcock approach. The central ray enters through a point 2 inch above the external auditory meatus. Okay, so that is what is happening with Grewcock approach. The central ray enters through a point 2 inch above the external auditory meatus. Okay, so you can see over here. And in Gill's approach, that is the third one, the central ray enters through a point half-inch anterior and 2-inch above the external auditory meatus. So you can just make a difference about the three techniques. In Lindborn technique, it was half-inch behind and 2-inch above the external auditory meatus. In Grewcock approach, it is 2-inch above the external auditory meatus. And in Gill's approach, it is half-inch anterior and 2-inch above the external auditory meatus. Okay, you can very well know. So in the first one, it was half-inch behind, whereas in Gill's approach, it is half-inch anterior. That is all. Okay, so that is how the technique is being varied according to the point of entry of the central ray. Okay, you can remember these three names. Now we'll see how the central ray is passing to our TMG of interest. So this is how it will be passing. So the transverse section, this is a transverse section that is being shown of the central ray passing through our TMG of interest. So this particular picture shows like the X-ray beam passes over the petrous pyramid contralateral. So above in contralateral TMG, and this is our TMG of interest. Okay, so this particular thing is our TMG of interest. So it is passing above the petrous pyramid in the opposite in the contralateral TMJ, and it is passing below the it is passing below the petrous pyramid in the TMJ of interest. Okay, so that is the point that is being told here. So that is how the X-ray passes. So we get to see something like this. Okay, we have already told we'll take in three position: open, rest, and closed mouth position. So this is in closed mouth position. This is in open mouth position. You can see your TMJ over here. Okay, so this can you make out? Here you can see your condylar head in the fossa, and this is how once a patient has opened the mouth. Okay, it has come outside the fossa, and it is there in the articular eminence. So we'll see one more clearer picture. So we have told already the angulation will be in between +20 to +25 degree. The X-ray, the central ray is being projected. This is the cassette, and this is how you get to see your joint of interest. Okay, you can see your condyle over here. Okay, and your condyle has moved outside the fossa. Okay, so that is how you get to see it. So what are the limitations? The subcondylar fracture cannot be seen because of the superimposition of the ipsilateral petrous bone and posterior clinoid process of the sella turcica. They are meant to say that there is a superimposition that is happening over this view from the ipsilateral petrous bone and also the clinoid process of the sella turcica. And also the radiograph shows only the lateral part of the joint, so that we have already told, right? So we can see only the lateral part. And also almost all the bony changes will appear laterally first. So this disadvantage can be overcome a little bit. So you can see over here, there's a lot of superimposition that is happening over here where we are not able to properly visualize if there is any subcondylar fracture that is happening. Okay, you can see over here. These are the limitations. So we can quickly recap. Our central ray is going to come at an angulation of +20 to +25 degree. The cassette is being placed flat against the patient's ear, and we are going to take it in 3 positions: open mouth, rest mouth, and a closed mouth position. Central ray is coming at +20 to 25 degree, and we have 3 techniques: Lindbaum, Grieve-Koch, and Gill's approach according to the point of entry of the central ray. Okay, so that is it about your transcranial projection. Coming to your transorbital projection, it is otherwise known as SIMMER or transmaxillary projection. It is minimum superimposition resulting in a relatively true in-phase projection. Okay, you can see over here, there's minimum superimposition in transorbital projection. So let's see the technique. First we'll discuss about the indication, and then we'll move on to the technique. So we can use it in case of trauma, if there's any fracture that is happening with the condylar head or neck. Then in case of fractures, to study the mediolateral acid displacement of the condyle, to study the superior surface of the condyle for osteophytes, and to study the relationship of the condyle to the articular eminence in mediolateral plane. Okay, we get to see the condyle in a mediolateral plane, and also if there's any bony changes that is going to happen. So what are all the areas that are going to be visualized in transorbital projection? The anterior view of the TM joint, the medial displacement of fractured condyle, and fracture of the neck of the condyle. So we have told in transcranial, we were visualizing the lateral aspect. So here we are going to see the anterior view of the TM joint. Okay, and also we can see some medial displacement and also the fracture of the neck of the condyle. So that is what we are going to see. So what is the technique now? So the film is placed behind the patient's head at an angle of 45 degree to the sagittal plane. You can see over here, the cassette is being placed at an angle of 45 degree to the sagittal plane behind the patient's head. How will we position the patient? The sagittal plane is held vertical. Canthomeatal line should be 10 degree to the horizontal with the head tipped downwards. So how are we going to make canthomeatal line at a 10 degree to the floor or to the floor? That is by tipping the patient's head, okay, downwards, and the mouth should be wide open. You can see over here the patient's mouth is being wide open. Okay. How is the central ray going to enter? The tube head is placed in front of the patient's face. You can see over here, this is your PID that is being placed in front of the patient. The central ray is directed to the joint of interest at an angle of +20 degree. Okay, so the central ray is going to be projected to the joint of interest at an angulation of +20 degree. Okay, +20 degree to strike the cassette at right angle. So the cassette is being placed at an angulation of 45 degree behind the patient's head, and the central ray is going to strike at an angulation of +20 degree. Now we'll see from where all the central ray can enter. The point of entry may be taken at pupil of the same eye, asking the patient to look straight ahead. Okay, that is one point of entry. Then medial canthus of the same eye. Okay, that is the second one. And medial canthus of the opposite eye. Okay, so the projection can be made from any of these 3 points at an angulation of +20 degree. Okay, so you get to see something like this. This is the pictorial representation of the positioning of the cassette and the central ray being entering at an angle of +20 degree. So you can see over here, you obtain an image something like this. Okay, see. Transorbital projection, again, a wider picture of the same thing. Coming to transpharyngeal view, so that is quite simple. You can remember the cassette is being placed at plus 45 degree and the central ray being entering at plus 20 degree, and the point of entry can be from pupil of the same eye, medial canthus of the same eye, or the medial canthus of the opposite eye. Coming to the third projection, that is your transpharyngeal view. Okay, it is also known as infracranial or McQueen-Bell technique. So, Parma view or transpharyngeal view. Okay, so this particular view bypasses the petrous pyramids by viewing the joint from below the base of the skull via the infracranial pharyngeal tissues. We are meant to say that the X-rays are going to bypass the petrous pyramids and viewing the joint from below. So this view is a lateral projection showing the medial surface of the condyle. So in the first one, we meant to see the lateral aspect, that is transcranial. In transorbital, we were seeing the anterior aspect, and in transpharyngeal, we are going to see the medial surface of the condylar head and neck. Okay. Typically taken in the mouth open position, allowing the joint to be projected into the shadow of the air containing spaces of the nasopharynx. So we are going to ask the patient to open the mouth and then project this transpharyngeal so that we are able to visualize the condyle, okay, through the shadow of the air containing spaces of the nasopharynx. Okay, so that is how we are going to take it. What are all the indications? TMJ pain dysfunction syndrome, joint diseases such as osteoarthritis, rheumatoid arthritis, pathological condition affecting the condylar head such as cysts or Ehlers cyst or tumors, and condylar head and neck fractures. So you can see over here, you get to see if there's any fracture in the condylar head and neck, if there's any this derangements, that is any TMJ dysfunction syndrome, all that can be visualized. So we'll come to the technique. How is the film being placed? The cassette is placed flat against the patient's ear and centered at a point of half inch anterior to the external auditory meatus over the TMJ of interest against the facial skin parallel to the sagittal plane. Okay, nothing. It is just placed in the TMJ of interest. Okay, you can see over there. Half inch anterior to the external auditory meatus. Okay, that is one thing to remember from this. Sorry. How are we going to position the patient? The patient is positioned so that the sagittal plane is vertical and parallel to the film. The occlusal plane should be parallel to the transverse axis of the film so that the soft parts of the nasopharynx are in line with the TM joint. The patient is instructed to slowly inhale through the nose during exposure so as to ensure filling of the nasopharynx with air during exposure. So in the previous slide, we have already told we are going to visualize the TMJ through the air-filled spaces. So we ask the patient to inhale. The patient should open his mouth wide so that the condyles move away from the base of the skull and the mandibular notch of the opposite side is being enlarged. Okay, so we ask the patient to open the mouth and also to inhale so that we are able to visualize the TM joint. However, how is the central ray being projected? It is directed from the opposite side cranially at an angle of -5 to -10 degree. Okay, so that is the angulation and -5 to -10 degree, and it is directed to the mandibular nodes. That is the window between the cornoid, condyle, and the zygomatic arch of the opposite side below the base of the skull of the TM joint of interest. So we'll see that picture, then it will be clear. Okay, we are going to direct the central ray through the mandibular notch. Okay, so you can see over here in this picture, the central ray will be passing through the mandibular notch to the condyle of interest. Okay, so that is how the central ray is going to pass. So this is again one more picture that is showing what we have told. This is how the cassette will be placed, and the central ray will be passing through the mandibular notch of the opposite side at an angulation of -5 to -10 degree, where we get to see your condyle like this. Okay, over here. You can see over here, the condyle will be visualized like this. This is with this we have already discussed. Then coming to the transpharyngeal view picture. So this is how you get to see your TMJ in the air, through the air-filled spaces. You get a very clear picture of your temporomandibular joint. You can see that neck and the condyle along with the glenoid fossa. So what is the limitation? The direction of the ray is oblique to the transverse axis of the ipsilateral condyle and directed from the inferior aspect we have seen. Thus, as a transcranial technique, the recorded image is distorted and the true sectional contour of the articular surface is not seen. Okay, so they meant to say that because it is coming from down and through the transverse axis, there's a possibility of distortion in the joint of interest. Okay, so that is our uh, limitation. Coming to the reverse down projection. So we'll quickly revise transpharyngeal projection. It is EC. It is otherwise known as intracranial or McQueen-Dell projection, where we get to see the medial aspect of the joint. The cassette is being placed in the joint of interest at half inch anterior to the external auditory meatus, and the central ray being projected at -5 to -10 degree through the mandibular notch of the opposite side. Okay, so that is how it is being done. Coming to the reverse down projection, it is primarily meant for viewing the condylar head and neck. The original Towns view is an anterior posterior projection. It was intended to show the occipital region and the condyles, but due to conventional dental skull views being taken in posterior anterior direction, the reverse down projection is being used. Okay, high fractures of the condylar neck, intracapsular fractures. This is the indication. Okay, high fractures of the condylar neck, intracapsular fractures of the TMJ, quality of articular surfaces, condylar hypoplasia, hypertrophy, all that can be visualized with your reverse down projection. This is how the patient will be positioned. Okay, patient's forehead should be touching your receptor and the central ray being entering at an angulation of 30 degree. The patient is in a forehead nose position with open mouth. That is another point to remember. The mouth is being open and the beam aimed upwards at 30 degree as shown in reverse down projection. You can see over here the beam is being projected at 30 degree. The radiographic baseline is horizontal and perpendicular to the film. Okay, you can see over here, this is your film, this is your central ray, and the patient is positioned so that the forehead is touching the film. What are all the indications? High condylar neck fractures, intracapsular TMJ fractures, examining the quality of the condylar head articular surfaces in the TMJ disorders, condylar hyperplasia, and it is also used to evaluate the bilateral symmetry. Okay. So this is how you get to see your reverse down projection. So you can see over here, both of the condyles will be seen. So you get to see if there's any fracture in the condylar head, condylar neck. Sorry. If there's any fracture, if there's any hyperplasia, okay, all that can be visualized with your reverse down projection. That is again a diagrammatic representation of the picture that we have shown, how the patient is being positioned and how is the central ray entry. The cassette is placed perpendicular to the floor in a cassette holding device. The long axis of the cassette is placed vertically, so it is giving a more explanation of whatever picture we have seen. You can just keep this picture in mind about reverse down projection. The position of the patient is same as that of PA view of the mandible. The sagittal plane should be vertical and perpendicular to the film. The film is adjusted so that the lips are centered over the film and only the patient's forehead should touch the film. Okay, you can remember that picture. The central ray is directed through the mid-sagittal plane at the level of the mandible and is perpendicular to the film. Okay, so all that you can remember. However, the Towns projection provide adequate visualization only if the mouth is open. Okay, so that is another thing where the patient will have to ask the patient to open the mouth, lowering the condyle out of the fossa sufficiently to eliminate the superimposition of the mastoid process located immediately posterior to the joint. So the patient's mouth should be open in order to avoid the possibility of superimposition of the mastoid process. Okay, so that's one thing. So what are all the limitations? They can be in case of advanced joint diseases where the patient is unable to open the mouth, will not be able to use this technique and also distort the profile of the condyle. Sometimes they can be a distorted condylar profile. Okay, so these are the limitations. Coming to the panoramic radiography, that is a good screening tool for evaluating the condyles because it uses the result in minimum superimposition of the structures over the condyles. Okay, it is a good screening tool and the lateral part of the condyle can be assessed with this technique. Okay, so you can see over here, this is the image. You get to compare both the sides. You can see if there's any fracture. Okay, all that can be seen. And also you get to see the lateral aspect of the condyle. So what are all the indications in panoramic radiography? If there's any degenerative bony changes, then if there's any asymmetries of the condyle, if there's any hypoplasia, trauma, tumors, okay, all these initial assessment can be made with panoramic radiography. Okay. So what is the limitation? The condyles are best visualized, but the articular fossa are often partially or not totally seen. Okay, can you see the fossa over here? Sometimes it can be obscure. Okay, so that is one limitation. But you can see the condyle and condyle head and neck can be properly visualized, but the fossa is doubtful because it is an intracranial view. The lateral pole of the condyle becomes superimposed over the condylar head, and the superimposition of the base of the skull and the zygomatic arch is restricted. The proper evaluation of the condyle and the glenoid fossa in the panoramic image. Okay, so there is a threat of superimposition. Other than that, we cannot see the fossa also clearly, but it is a good tool, screening tool to evaluate the symmetry and also if there is anything on the first view. Okay, good screening tool. That is about the panoramic radiography. Coming to computer tomography, it has been employed in the detection of uncommon disorders such as synovial osteochondromatosis as well as bony abnormalities of TMJ. The wide range of osseous pathological alterations, including osteophytes, condylar erosions, fractures, ankylosis, dislocation, internal disc derangements, growth anomalies, and like condylar hyperplasia, etc., can be visualized with your computer tomography. So multi-detector CT, MDCT is more widely available and better tolerated, and the slice thickness and interval should be between zero point 0.5 to 1 mm. So we can do a reconstruction. So this is a sagittal reconstruction. So this the plane is being selected, and this is a sagittal reconstruction. This is a coronal reconstruction. This is the three-dimensional 3D reformated images, and this is a two-dimensional panoramic picture that has been reconstructed. Okay, so that is how we get to see each part which is in the area of interest, and that can be visualized in various planes, sagittal, coronal, and um, uh, in 3D reconstruction and also in panoramic imaging. So coming to cone-beam computer tomography, it offers a high spatial resolution that is very well useful for us. So it offers a high spatial resolution and less scanning time, making the preferred imaging modality of the maxillomandibular regions compared to multi-MDCT. Imaging diagnosis is crucial for evaluating TMJ conditions. We can see almost all the pathological conditions, assess the bony structures, assess the position of the condyle within the glenoid cavity, helps to confirm the progression of the disorders, and also how is the treatment that is being done is progressing. Okay, evaluate the treatment effects, and also the other factors to be considered in the condylar fractures, neoplasms, malformations, etc. Potential solution to penial wall continuity, all that can be evaluated with your cone beam CT with the area of interest. And also you get to see it in all the three planes, and a 3D reconstruction can be seen, and also two-dimensional reformation as a panoramic image can also be visualized. So you can see over here the glenoid fossa, your articular eminence, condyle, external auditory meatus, the neck of the condyle, mandibular ramus. Okay, all that is being clearly visualized with the help of CBCT imaging, and it is preferred as well compared to MDCT. Now, coming to soft tissue imaging, we have magnetic resonance imaging and arthrography. So we'll see how is MRI going to help us. MRI is currently considered the reference method for imaging the soft tissue structures of the TMJ, such as your articular disc, synovial membrane, and lateral pterygoid muscle. So whenever we were discussing, if you remember, discussing the anatomy of TMJ, we have told the soft tissue aspects, the articular disc, synovial membrane, and the lateral pterygoid muscle. So we get to visualize these in MRI, and has been pointed out as the best imaging modality in diagnosing this displacement. So if at all there's any problem with this, if there's any disc derangements, we can see it with the help of MRI. It could also detect the early signs of TMJ dysfunction like thickening of the anterior or the posterior band. We are talking about the disc, right? Then rupture of the retrodiscal tissue, change in shape of the articular disc, if there's any joint effusion. Okay, all that can be visualized with magnetic resonance imaging. So the images are obtained in all three planes, sagittal, axial, and coronal planes. So the most scanning sequences, T1 weighted image, T2 weighted image, and PD images are obtained. Okay, we get the images in all these three images. The proton density PD images serve to visualize the disk condylar relationship. Okay, so you can just remember this point. The disk condylar relationship can be obtained, can be seen with PD imaging, while T2 weighted images are used to diagnose the inflammation in the joint. Okay, T2 weighted images is used to see the inflammation in the joint. The slice thickness is important for image quality. The most frequently used section thickness being 3 mm. Reducing the slice thickness can improve the quality, but it requires a lot of scanning time. Okay. So the MRI scan can reveal what all can be seen. It can be both open and closed mouth views in an oblique sagittal plane with the section oriented perpendicular to the long axis of the condyle. You can see in all three planes. Okay, that is what is being told the coronal plane, which make it easier for identification of the lateral and medial disc displacement. Okay, if it is in the if it is in coronal plane, we can easily see the lateral and medial disc displacement. So there is an MRI, where it is being done in closed mouth and in open mouth position, where you get to visualize the disc in a more proper manner. Okay. Now moving on to arthrography. Arthrography is an invasive technique for diagnosing TMJ, soft tissue derangement. So we have told that MRI is the best method to see the soft tissue structures. Then why do we have to do arthrography? We'll see that it is the most commonly used method for diagnosing soft tissue, TMJ soft tissue derangements as MRI. Okay, that is what we have told. MRI is most commonly used. Why do we have to do arthrography? It is because if there is any, if there's any one second. If there is any inflammatory changes or if there is any disc punctures that can be visualized with the help of arthrography, okay, compared to your MRI. So, however, MRI cannot reveal the conditions like adherences and perforations. Okay, if there's any disc punctures or if there's any perforations that cannot be visualized in MRI, that we get to see in the arthrography. Then the functional examination is possible in arthrography. They are superior to MRI movies for the same reason. Okay, so that is how. Arthrography is the method of choice for soft tissue diagnostic when MRI is contraindicated. So in which all cases MRI can be contraindicated due to loss of loose ferromagnetic subjects in the objects in the body, or metal objects like your orthodontic wires or braces in the head and neck region, causing disturbance in the image of the patient is suffering from claustrophobia. Okay, so all these cases, MRI is contraindicated. In that cases, we can go for a arthrography. It is also useful for guided therapeutic injection. That means it is also used for therapeutic purposes rather than diagnosis. It can also be used for therapeutic purposes in case of administering corticosteroids. So in which all cases, this arthrography is being indicated. So in case of clinical signs of TMJ arthralgia, arthritis, including pain on jaw movements, that is first thing. So no or minor pain relief after justified conservative treatment. So once we get to know that there's some TMJ disorder, we go with the conservative treatment, right? So if there's no relief, even after the conservative treatment is being, and the NSAIDs or the occlusal splints or the jaw exercises, all that is being tried, and the patient is not getting relief, you can go for this arthrography to find out the reason. Clinical signs of possible internal derangement or adherences with the clinical examination, we come to a diagnosis of internal derangement. Okay, so then we can go for an arthrography. It is also useful for evaluation of soft tissues of the TMJ to determine the position, configuration, and dynamic function of the TM joint. Okay, soft tissue of TMJ. Then for verification of suspected adherences and perforation, this is an important thing. Okay, so perforation and adherences, which is not being seen with the help of MRI. So that is also being seen, being used with arthrography. What are all the contraindications? We know that we use some contrast media, right? So if there is any previous reaction to iodine contrast media, we cannot use this arthrography. Anticoagulant medication or bleeding disorders. The patient is having the non-history of this, then we cannot use it. The patient is having anxiety, and if there's any history of acute infection in the preauricular area. Okay, these four are the most important contraindications. So, how are we going to position the patient? Now we'll see the technique. Okay, the examination is performed with the patient in a supine position, lying on the side with the TMJ of interest facing upwards. You can see how the patient is being lying down. The patient's head is tilted slightly towards the table and rotated upwards. Okay, the patient's head is slightly rotated upwards. The vertical positioning of the C arm with the X-ray source under the examination table results in a lateral oblique transcranial projection. Okay, so with this, when we take the imaging, making the patient's head slightly tilted and rotated upwards, we get a oblique transcranial projection, something like this. You can see in this picture. It prevents the superimposition of the contralateral dense petrous part of the temporal bone. Okay, so that is why we are going to position the patient like this, and we get something like this oblique transcranial projection, something like this. So, what is the technique? The TMJ arthrography is performed by catheterizing the upper and the lower joint spaces and injecting a zero point 0.5 to 1 ml of radiographic contrast media, iodine contrast media, first into the lower joint space. Okay, first into the lower space and then into the upper space. Okay, we are going to inject the contrast media. And the most commonly used is iodine components that we have told. A series of radiographs are taken following the point space opacification with the jaws closed and graded stages of opening. So once the dye is being injected, we are going to take a set of radiographs with the patient's mouth closed and in graded stages of opening. Okay. The disc appears as a radiolucent void between the two opaque areas of the contrast medium. Okay, so we'll see how the disc is going to appear. So this is how we are going to inject the contrast media. Okay, and this is how your joint is going to look like. We'll see a more clear picture. So you can see over here, you can see the disc as an opaque area in between the contrast media. Okay, this is your superior cavity and this is your inferior cavity. If at all there is any dyspuncture of perforation, you can see the contrast area being displaced. Okay, so that is how you get to see this, and this is how your disc is going to appear. So, what are all the complications that we can expect in arthrography? It is an invasive method and requires the use of ionizing radiation. Making a reliable diagnosis regarding the sideways disc displacement without CBCT examination is difficult. We have already told CBCT can be the most reliable method. Okay, so that is not being used. Then, fluid injection into the joint can impair the joint function during examination. Multiple attempts to locate the compartments can cause iatrogenic perforation of the disc or the posterior attachment. Okay, so we are trying to locate the compartments in multiple times, and there can be iatrogenic perforations. Local complications of intra-articular injections include bleeding and pain. You get to get bleeding and pain. If we are trying to inject corticosteroids, transient increase in pain or steroid flare can happen. Mild headache and facial flushing can be a complication. While administering local anesthesia, a risk of anesthetizing the other uninjured nerves, particularly the facial nerve, resulting in transient facial nerve palsy, can also happen. Okay, these all are the complications. There can be impaired joint function. If there can be iatrogenic perforations, there can be bleeding, pain. Then, if corticosteroids is being injected, then there can be steroid flare, headache, facial flushing, and if LA is being if LA is being tried and uninjured nerves are being anesthetized, mostly facial nerve, you get to get transient facial nerve pulse. Okay, so that is it about the soft tissue ears imaging in TM joint. Coming to the conclusion, so the selection of proper radiological technique for TMJ as well as of the patient must be carefully made by the practitioner in correlation with the clinical signs and symptoms. So, with the clinical signs and symptoms, we are going to evaluate and take the proper radiograph depending upon which area we have to see. And the purpose of the chosen radiological investigation must improve the diagnosis and treatment outcome. Okay, that is our primary aim. It should aid our diagnosis and also it is going to benefit the patient. Okay, so that is how the TMJ imaging is going to help us. So these are the references. Thank you.